Good evening and welcome to part 2 of What is PANDAS, PANS, the science and research behind treatment, presented by Dr. Allison Christie, Clinical Director of Providence Pediatric Neurology. We would like to take this moment to acknowledge and honor that we reside and serve families on the ungifted land of the traditional inhabitants of Oregon, who have stewarded it throughout the generations, including the 9 federally recognized confederated tribes in Oregon. Let this land acknowledgement be an opening for all of us to contemplate Indigenous movements for sovereignty and support their self-determination. My name is Janet and I am the Family Education Coordinator for the Swindells Resource Center. The Swindells Resource Center of Providence Child Center supports all families, parents, and caregivers, especially those of children who have special health, behavioral, or developmental needs. We provide resources, parent coaching, and education to communities throughout Oregon and Southwest Washington. For more information on upcoming events, support, and resources, our lending library, or to request a care notebook organizer, please visit our website or contact us at swindells@providence.org or by phone at 503-215-2429. We would like to thank the Providence Children's Health Foundation and its generous donors for helping make this event possible. Thank you to those who submitted questions ahead of this event with your registration and via email. Dr. Christie will touch on the submitted questions tonight, and if you have additional questions after this presentation, please note them in the post-event evaluation or email the Swindells Resource Center at swindells@providence.org. Please join me in welcoming Dr. Allison Christie, Clinical Director of the Providence Pediatric Neurology.
Hi, I'm Dr. Christie. Thank you guys so much for coming, and thank you guys so much for coming last time. I was so excited to see all your questions. I don't know if you've given a talk over Zoom, but it can feel very much like you're just talking out into the void, and so when people respond to these questions, it really feels like we have a connection, and I really appreciate that. I'm Dr. Christie. I am Director of the Pediatric Neurology at Providence Health and Services, and also I'm a pediatric neuroimmunologist. I have a PhD in immunology, and we are building the Providence Center for Pediatric Multiple Sclerosis and Neuroimmunology. And I assume that you've probably seen the previous talk, PANDAS PANS #1, and that's why you're here today. I am going to give a little bit of a review about what we talked about last time. If you haven't seen that, please go back and look at it. And again, if you have more questions after this one, like Janet said, please email Swindells. We can always do this again, and I'm also happy to talk about your specific questions in clinic at any time. So keep that in mind. So last time we talked about PANDAS. PANDAS described by Susan Sweto in 1994. She noticed that sometimes when kids had strep, they developed severe tics and OCD afterwards. And as the strep got better, those symptoms went away. And she called it PANDAS, or Pediatric Autoimmune Neuropsychiatric Disorder Associated with Streptococcal Infection. And because a lot of kids have tics and a lot of kids have OCD and a lot of kids have strep, there was a need for some kind of way to distinguish the kids that we thought had PANDAS from the other kids, right? So she came up with clinical criteria in 1998. And so the clinical criteria includes OCD and tic disorder, childhood, prepubertal age of onset, a sudden onset and a waxing and waning or relapsing remitting course, and a temporal association between the time that you got sick, the time that these symptoms happened, and a strep infection. And after 1998, there was this idea that, if there was an infection and then you had symptoms, there must be some kind of post-infectious thing going on, something inflammatory or autoimmune. And so there's a lot of look for something like a biomarker. And a biomarker is something like a blood test or an imaging study, something that we could do to say, you are the kids who have this thing going on. You are the kids who don't have this thing going on. Now we can study you and figure out how to treat you. But it's been very difficult to find a biomarker for PANDAS or PANDAS. So in 2012, moving on, they published the PANS criteria because they knew that most or some kids didn't fit in the PANDAS phenotype, but they still had a lot of things going on. And so they called it PANS, or Pediatric Acute Onset Neuropsychiatric Syndrome. They took out the word autoimmune and the criteria changed a bit. So now it's abrupt traumatic onset of OCD or severely restricted food intake. And like I said last time, I think that's an important piece of it. I think it's kind of a fascinating thing that's happening in the brain. And then presence of additional neuropsychiatric symptoms, which again should be something that comes on all of a sudden. Generally, these kids, when you see them, it's like everything has been fine and now they have fallen off a cliff and everything is not fine. And this list of things that can be happening, including anxiety, emotional ability, irritability, behavioral regression, change in school performance, motor abnormalities or sensory changes, and then somatic signs and symptoms like sleep disturbance or problems with urination. And this is a very different criteria from what the criteria was for PANDAS. And now things have changed a little bit more with time. So now the PANDAS Physicians Network is recommending this flow chart. And again, it's because we don't have a way to really say, you are the kid who has PANDAS PANS, you are the kid who doesn't. So they say, okay, when you're evaluating a kid, these are the things you should be thinking about, and this is how you might think about them going forward. And so they say if you have a child, and this is just like the PANDAS criteria that we talked about before, who has sudden onset of OCD, or sudden onset of eating restriction, or sudden onset of motor and vocal tics, and all these comorbidities, then you should think about something like PANDAS PANS. They do actually recommend checking with a throat swab for strep. And if you have a symptomatic strep infection, treating with antibiotics makes a lot of sense. They also recommend ASO and anti-DNase B, but they also say that many kids don't actually have ASO or anti-DNase B titers, even if they've had a strep infection. And so it doesn't necessarily even distinguish between PANDAS and PANS. It doesn't necessarily change your management of it. I generally don't recommend checking it because it doesn't necessarily tell us what's going on. And then once you get through this flow chart, then you say whether the case is mild, moderate, or severe, and treat accordingly. Talked about the Cunningham panel, and you'll notice the Cunningham panel is not in that flow chart. And the Cunningham panel is looking at certain antibodies to antigens that are present within the basal ganglia, an internal part of the brain that controls motor movements. Not whether or not you can move, but kind of an on and off switch for the motor system. And basically, Cunningham panel has been shown to not really be particularly specific for something like PANDAS PANS. It's positive in a lot of normal kids, and it's not positive in kids who seem to really fit the PANS criteria, so it's not super helpful. And it's expensive, and insurance usually won't pay for it. We also talked about the fact that, you know, this was described with strep, but then we also see it in the PANS criteria. They don't even mention infection at all, and certainly other kinds of sicknesses seem to lead to things like PANDAS PANS. And there was a description of PANS after COVID even. And this list here is showing you that they tested for a whole bunch of other infectious diseases and didn't see them. They did see COVID. The brain MRI was normal. And so it may be that it's not so much which infection you get, it may be something more about how your body responds to that infection, or it may be that very specific infections cause this kind of thing. So when you have a sickness that happens after an infection, that sickness could be from the infection itself. If you think about someone who has meningitis when they're little, they could have long-term sequelae from that meningitis. They may always have neurodevelopmental differences because they were sick when they were little. They could have damage in their brain that is always there. It could be from the inflammation, meaning that when your body is responding to that infection, you get an inflammatory component that either causes damage or is still ongoing. Or it could be something that's autoimmune, meaning that your body started responding to that infection and now is responding to self tissues. And your immune system generally does a very good job of distinguishing between self and non-self, but sometimes that breaks down and sometimes you have a problem. So we don't have great data for any of those etiologies of PANDAS PANS. And we'll talk more about what we do have in the way of data talking about that to address those things. And we don't entirely know how to treat it. We don't have great evidence for the things that we use to treat it. So because we don't have great evidence, which is, this is a quote from one of these articles, the groups that were studying PANDAS and PANS worked on coming up with a consensus guideline, which means that even though we can't say 100% that this is proven to be the treatment, we feel like, having seen a lot of these kids, is the best way to go. And they came out with 3 papers in 2017 looking at immunomodulatory therapies, treatment and prevention of infections with antibiotics, and then things like psychiatric and behavioral interventions. When I see parents who are concerned about PANDAS PANS, oftentimes what I hear is, I'm worried, I don't want to treat the symptoms because what if I'm missing a root cause? And what if I treat aggressively with something that's immunomodulatory? I might be able to avoid all of the psychiatric and behavioral interventions. I might be able to not put a Band-Aid on the symptoms that we have, but actually treat the underlying thing that's going on. And that is, of course, what we want for our kids always. But I want to point out that even with immunomodulatory therapies or antibiotics, generally what's recommended is things like psychiatric and behavioral interventions anyway. So those things all work together to make kids better. Those consensus guidelines came out in 2017, and since then we still haven't found a real evidence for the treatments. So the PANDAS Physician Network again came out with treatment guidelines to make it very clear how you treat kids when they come in with mild, moderate, or severe cases. What they recommend with a mild case is antibiotics, and then maybe thinking about NSAIDs and having cognitive behavior therapy, having some kind of psychiatric support for the child and for the family. With moderate symptoms, they recommend antibiotics and prednisone, considering IVIG, and then things like cognitive behavioral therapy as well. And you can find these charts online if you look for them. And then with a severe case where symptoms are incapacitating or life-threatening, of course, you want to evaluate and make sure that you're not missing something else. Make sure that you're very certain about the diagnosis of PANDAS PANS, because there are many different things that can cause behavioral changes in children. And some of them are treated like PANDAS PANS and some of them are not. So you want to make sure that you've really got the right diagnosis, especially in a case where things are really severe or life-threatening. And then things like IVIG, antibiotics, steroids, and of course, seeing a psychiatrist and also cognitive behavioral therapy and things like that. Talked about how the PANDAS network looked at a lot of different treatments for kids. And the treatments for PANDAS and PANS are very, very broad. And what people respond to seems to be very different depending on who they are. A lot of kids have received antibiotics, supplements, some have received steroids, fewer have received IVIG, plasmapheresis or rituximab, and they looked at over 1,000 kids, which is pretty awesome actually. And then they asked them what worked for you. And it's kind of all over the map, what worked for people or not. One of the things that comes up highest in the very effective category is other antibiotic, which is probably things like azithromycin. IVIG multiple has about a 15% very effective rate. Some people say it's somewhat effective, some people say it's effective at first and less over time. The point is that there's not really a clear one-size-fits-all approach to this kind of thing. There's going to be some clinical judgment, and even in those treatment guidelines, there's a lot of consider this, think about this, there's a lot of clinical judgment involved to figure out what might be best for your kid. About ticks last time, and ticks are in and of themselves not necessarily a problem. And yet often when I see parents who are worried about PANDAS PANS, the thing that they're most focused on is my kid didn't have ticks before and now they have ticks. Lots of kids have ticks. That's a really common thing. They are sudden asymmetric movements of the body, and they are associated with an urge or like a pressure, a tickle, a feeling that things are not right. And then when you do the movement, you get this relief. They can be suppressed just for a second or just for a millisecond even, and but then it becomes so uncomfortable in your body that it's not worth it to suppress it anymore. So you end up having the tick. And we talked about how a combination of motor and vocal tics for more than a year is the definition of Tourette syndrome. It doesn't mean you won't outgrow it. It doesn't mean we have to treat it. It just means that you have both motor and vocal tics. And when I say vocal tics, I don't generally mean words or certainly not curse words. Generally, vocal tics means things like sniffing, throat clearing, humming, clicking. Lots of kids have these like little vocalizations that they do in Tourette syndrome. It's usually come out around elementary school. And I mentioned this last time, I think it's more the exception than the rule. And usually they're going to go away by adolescence. Usually kids grow out of these. They can certainly come on very suddenly. And anyone who has a kid who has tics knows they can come out of the blue and just be terrible. And then they can go away and then they come back. Tics tend to wax and wane. That's kind of what they do. They happen more when kids are anxious, but they also happen more when kids are watching television, when they're super distracted, when they're playing a video game, sometimes when they're reading. Basically, your frontal lobe shuts down. It's not controlling your basal ganglia anymore. And so you get a whole bunch of tics. And we don't treat tics unless they are disturbing to the kid, not disturbing to the parent, not disturbing to the teacher. We don't treat because there's a bully. We address the bullying instead. But if the child is saying, it's uncomfortable in my body, I'm upset by this, then we treat with medications or with habit reversal or CBIT. Resources for that. Dr. Kurt Friedman at OHSU does a lot of CBIT with kids, and he's very excellent. And Maggie Stokel at the Children's Program is also very good with this as well. What it does is it teaches kids to identify that urge, that feeling that I need to move or it will be uncomfortable in my body. And then you try to do something that's incompatible with that urge. So I mentioned this last time, my kid had a tic where he would throw his head straight back. And so I asked him instead to shrug his shoulders. And so we did both for a while, and then he just shrugged his shoulders and it kind of went away. And that's kind of what we're looking for, is something that, and that wasn't, you know, you could kind of do them both at the same time, but you're looking for something where you can't really, you have to do one or the other. If kids have a tic where they're hitting themselves, which is pretty uncommon, we'll ask them to clap, that kind of thing, because it kind of fulfills the same function. When we use medications, we're often not using medications that really work on the tic pathway. We're using things like guanfacine, which kind of calms you down. We use it for anxiety. We use it for, it's a blood pressure medication, but we use it for anxiety. We use it for things like emotional outbursts and things like ADHD. Topiramate, which is a seizure medication that's used more commonly for migraines, can somehow be can help with tics. And then in extreme cases, we use antipsychotics. And I said last time, you know, I almost never prescribe antipsychotics for kids. And of course, I saw a kid this week that I did that for. You know, they never say never. Sometimes these things are really necessary. And antipsychotics can be excellent in really stopping the tic and making it go away entirely. That's what we do with tics. And we talked about social media related tics, where they're not really like an organic tic that's coming from the basal ganglia, but some kids have what's called a functional movement disorder, meaning that it's not organic, it's kind of there's a psychological component to it. And what we see in this arena is teenagers who have a sudden onset of very explosive tics, and they are weird looking tics, and they will hit the wall, they will hit themselves, they will say silly phrases with weird voices, they will whistle, and it doesn't quite look like the tics that we see in elementary school kids. They're less likely to report a kind of urge, they're less likely to report the ability to suppress it. They're less likely to occur if they're on their own or if they're just watching television. They tend to happen at the dinner table. And usually if you ask them, you can find out that they've been watching videos of tics online. Sometimes they'll say, a friend of mine does this. And the treatment is different than treating a tic that's an organic tic from the basal ganglia. And generally it involves avoiding the social media and things like psychotherapy and OT. These things can be difficult to treat. What about psychogenic non-epileptic spells, or PNES, during COVID? And what are the resources for this? And thank you so much for asking that. PNES is, these are spells that people have that look like seizures for whatever reason. They stop what you're doing, they're involuntary, and you're having this event, and then it stops in the way that a seizure does. But a seizure is electrical activity in the brain. So normally your brain neurons are all doing their own thing. They're firing all by themselves. And then in a seizure, they're all firing together at the same time. Just it's too big and it's too synchronous. And that doesn't happen in a psychogenic non-epileptic spell. That electrical activity isn't the thing that's happening. I haven't personally seen more PNES after COVID. It's something that we generally see just, you know, consistently throughout the year. I do know I'm in a large network of female neurologists, and there have been some reports about social media again triggering this kind of event if people are watching videos of people having spells like this. Then the second question, what are the actual resources for this? And this is where we as neurologists are not necessarily the best. FND Hope, or Functional Neurological Disease Hope, is an excellent website. They have things on there that are like 10 myths about FND. They have a find a provider section where you can type in where you live and find a provider that's local to you. I learned a lot from that website because unfortunately as neurologists, we're not trained a lot in these non-epileptic things. We're trained a lot about epilepsy, but not a lot about the other stuff that might be more functional. And I'm going to tell you about a textbook, which is not a thing I normally do. I wouldn't normally send you guys to see a textbook, but I thought this was really helpful. And there aren't a lot of things out there that I know about that are really helpful. So this is a free textbook available through springer.com, Functional Somatic Symptoms in Children and Adolescents. And what they recommend for treatment is working with the body, working with the mind, and working with the family unit. That's just a simplification of what she says in the book, Kasia Kozlowski. So if you're really interested and you really want to get into it, that's a resource that I recommend. If you talk to your pediatrician or your psychiatrist, they might have other resources for you as well. So a lot of the questions were around the data for inflammatory pathogenesis in PANDAS PANS, and actually asking about specific papers, and I'd love to talk about that with you today. So when we talk about PANDAS PANS, a lot of what people are thinking about is what we know about autoimmune encephalitis, specifically anti-NMDA receptor antibody positive encephalitis. So this was discovered in 2004, like we talked about before, and this was mostly young women who were presenting with ovarian teratomas and a lot of psychiatric symptoms. And they would have things like seizures and autonomic dysfunction and very clear and obvious neuroinflammation. If you tap someone, they've got white blood cells, we call that pleocytosis, and they've got antibodies present in the cerebrospinal fluid. And we found out pretty quickly after this was discovered that these are actually antibodies to antigens on the cell surface, the NMDA receptor that's on the surface of the cell. And this is showing this beautiful picture, whereas previous autoimmune encephalitides discovered back in the 60s were antibodies to antigens that were inside the cell, so proteins, things that were in the cell, the antibody would bind and cause problems with the cell. So NMDA was something different. And we figured out, again, pretty quickly after this was discovered, that what happens is the antibody comes and binds the receptor, and then the cell takes the receptor inside the cell. So the cell is still there, the cell is still functioning, the cell is not functioning right because that receptor is gone. And so we know that early aggressive treatment can really be helpful in NMDA encephalitis. And when you look at these different autoimmune encephalitides, you see that IgG binds and you get this brightly lit up brain. So this is the negative control here. And these are mouse brains that we're looking at. And then with NMDA or the various different autoimmune encephalitides, you get binding of IgG from the patient in different areas of the brain, depending on what kind of autoimmune encephalitis that they have. And it's really clear and it's very pretty. If you look at someone with PANDAS, they look more like this negative control, and that's why it's a controversial thing. That's why we have difficulty saying that it's something neuroinflammatory, and that's why we have all of these, that's why we have talks about it like this, right? And why we don't have a biomarker. So in 2009, this paper came out looking at basically that. They were trying to show that picture with something like PANDAS PANS. And they took 30 kids with the diagnosis of PANDAS, 30 kids with Tourette syndrome, and 30 kids who were just, controls. And they didn't see that IgG bound in the brain more more in the kids with PANDAS than in the normal kids. But what if it's not such a dramatic thing? What if it's, what if it's not the negative control versus the positive right here? But what if it's just binding to a few cells? Couldn't that cause a problem as well? And so what they did is they looked at these specific cholinergic interneurons within the basal ganglia. And they looked at those particularly because the basal ganglia are involved in tics, and they were thinking that those would possibly, if you had a derangement, if you had a problem with those specific cells, you could have problems with activity, and that could possibly lead to things like tics. And so what they looked at in the mouse striatum, this is the box right here that we're really looking at. Here's the control and the binding of IgG from serum of patients with PANDAS to these interneurons in the striatum. And here are the PANDAS kids. And it's statistically significant. And it's statistically significant because you're looking at a lot of people. But it's not a really clear and obvious difference. As you can imagine, you couldn't really look at cholinergic binding and say, oh, that is clearly a PANDAS patient, or that is clearly a control. So it's not really the biomarker we want clinically. I can't send your child's serum off to a lab and have them look at this and tell you whether or not they have PANDAS, right? And they say that in the paper as well. They say, it's not specific to PANDAS. PANDAS is a clinical entity. Like I was saying to you before, this is a clinical diagnosis. This is not something we diagnose in a lab. We say, does your child check off these boxes? They have PANDAS PANS, not we did this blood test and can tell you whether your child has this or not. And then this is just showing that it's not there in the other cholinergic neurons in the medial striatum. It's not there in the putamen. It's not there in I'm blanking out what the figure is. Oh, that's looking at the normalized intensity. So yeah, this is basically a negative control. And then they stimulated the cells with a glutamate agonist. So glutamate is generally going to be a stimulating thing to neurons. It's an activating as opposed to GABA, which is generally going to slow it down, right? And then they looked at patch clamping. I'm not a patch clamper. I'm an immunologist, so I didn't do a neuroscience PhD, so patch clamping is not my thing. But what they saw is they saw a change in AMPA between the two different types of, when they were doing serum from children who did not have PANDAS versus children who did have PANDAS. They saw a change in response to dopamine, and they saw a change in response to serotonin, and the change in response to serotonin looks pretty dramatic. And this is part of the supplemental figures of this paper. And they stimulated cells with the glutamate antagonist, and they looked at something called phospho-RB56. This is not a standard thing that we use to show activation in cells, but they did a proof of principle in the supplement, and so they think that this is showing that these chat interneurons have a different function than they would otherwise, which seems okay. And again, it's a pretty subtle difference, but it is statistically significant when you look at control versus PANDAS. And then they looked at the control group. So this is the control group. They have glutamate stimulating the chat interneurons, and then they've also been incubated in this serum from children who do not have PANDAS. And they looked at children who have the PANDAS, right? So there's some overlap, but there's a statistical difference. And then they saw when the children got IVIG who had PANDAS, that there was a change. So that's pretty cool. And then interestingly, they saw that when you took the IgG out of the serum, meaning the immunoglobulins that are there, that you also, you didn't have this change. So if you took the IgG out of the children with PANDAS, then you wouldn't see this difference, which is sort of fascinating, right? Because they're arguing here that IgG is binding to these interneurons, but it's significant, but it's like kind of the same amount, right? Like there's not a dose response where more seems to make a difference. And yet the IgG is the thing that they're arguing is making a difference. And it's one of those things where you're like, well, this is probably a key thing, right? Because it seems so weird. Why would those two things both be true? And it may be that if we took the IgG out of the children with PANDAS and combined it with serum from the control group, we'd find out that there's something else in the PANDAS serum that's also causing an issue. Maybe they need the two hit in order to have this decrease in actual function of the striatal neurons. I know that a lot of people want to read this study and say this means that children need IVIG. It's not really how we determine whether a child needs medication or not. If you can think about it, there's a lot of medications that may work on a slice of brain in a lab, and they're not going to necessarily work when you put them inside a human body. And the COVID vaccine is an example of that. We had to do those placebo-controlled trials, regardless of whether we thought that it worked in a lab. This is an interesting study that I didn't actually get asked about, but I think it's really cool. So they looked at, this is the group at Stanford with Jennifer Frankovich. They looked at MRIs in patients with PANDAS PANS, and I'm often asked if you could just do an MRI that would say whether or not there's something wrong with the basal ganglia in your kid. And what they looked at is something called an apparent diffusion coefficient. So this is not from the paper, but I just wanted to illustrate the point. This is a MRI of a brain. It's looking at it this way. So parallel to the ground. And these are the ventricles that are bright. They contain fluid, and that's a T2 image. This is a different type of image. Now you can see the fluid here is dark, but this area here is bright, and that's called a DWI, or diffusion weighted image. We usually use this in stroke. So this is a picture of a person who had a stroke, and the stroke turns bright because the fluid isn't getting in there, and that's why it's called diffusion weighted, because we're looking at the diffusion of fluid into this area. Blood isn't getting to the area. It looks really bright. And we use the ADC actually to say, is that real or not? Because in the ADC, if it's not real, it will be really bright. So if this were bright here and bright here, we'd say not a stroke. Because it's bright here and dark here, we say it is a stroke. So they looked at ADC, which is an odd measure, and I don't exactly know why they picked it, but It's not necessarily a measure of inflammation, but it is telling us that there's something different about these brains, right? And that's kind of the important thing here. And we're looking at the basal ganglia of these children, thalamus, caudate, putamen, pallidum, amygdala, nucleus accumbens, except for the amygdala, those are all things within the basal ganglia. And they're showing a difference in the children with PANDAS PANS. It's still not something that you could use to say, these are the children with PANDAS PANS and these are the children who don't have it. Because here are the control kids, but you can see there are certainly some open circles in there as well. And also they're using a very specialized software to make these very intricate distinctions between the child, the measurement of the ADC. Like they're using a software that looks at this very closely, and I don't have that software and it's not generally available. So it's hard to use it in clinic. I can't take a picture of your kid's brain and say, oh, their ADC is up in their thalamus, so therefore they have PANDAS PANS. It's still a clinical diagnosis, but it makes it very interesting for studying because you could possibly take these kids who have all these open circles up here and you could just look at them. And even if you're missing these kids who are down here, maybe that would be worthwhile to say, does the medication work? Because it would give you some kind of biomarker to use in a study, which is pretty cool. There's also a mouse model. Hold on a second. Looking at strep infection in mice and looking at cells that come into the brain after you have a strep infection in mice. So they noted that humans, if you take out their tonsils, they have Th17 cells in their tonsils if they've had group A strep. And if you spray group A strep into the nose of a mouse, then they get these Th17 cells in their brains. So what's a Th17 cell? I'm so glad you asked. I love this stuff. So when I started in the lab way back a million years ago, when I started my PhD, I was working in a mouse model of MS, multiple sclerosis. And we knew 100% that multiple sclerosis in mice and probably in humans was caused by Th1 cells. So you had dendritic cells that were out in the peripheral tissues, in the skin, in the gut, in the airway, and they get some kind of antigen, some kind of insult, and then they mature and they activate and they move to the lymph node or spleen and they activate T cells. And the T cells are these immune cells. The dendritic cell is actually the one expressing either IL-12 or IL-4. Those are cytokines, which are just chemicals released from the dendritic cell that are changing what the T cell does. And then the T cell differentiates. We call it skewing into Th1 or Th2 cells. And at the time that I started my PhD, that was all we had was Th1 and Th2. And those Th1 cells make these cytokines, and the Th2 cells make these cytokines. And people say Th2 cells are anti-inflammatory, but they're not really. They're really more for helminths or parasites, a different kind of infection that we don't generally get anymore. So we knew that Th1 cells were the important cells in multiple sclerosis, but we also knew that things were weird. We knew that if you blocked interferon gamma, for some reason you got worse disease, which makes no sense if these are the pathogenic cells. And most of us said, well, we're just going to ignore that doesn't work. We're going to ignore that doesn't make sense because this is how we understand it and we really kind of want it to make sense. And then one lab figured out that it's not those Th1 cells at all. It's actually Th17 cells. Th17 cells were called that because they make IL-17. Does that make any sense? No, it doesn't. I mean, you got Th1, Th2, and Th17. There's really no Th3 through 16, but okay, fine. So Th17 cells seem to be the main cell that's involved in multiple sclerosis and in this mouse model of multiple sclerosis. And the Th1 cells help it out a bit, but really you need the Th17 cells to make disease. And so, and that's the primary way in which Th17 cells are understood. So when they look at this mouse model of group A strep, they are looking at whether the Th17 cells are present in the brain after spraying it into the nose. And I was asked specifically to talk about these papers, so that's why I'm doing it. They took mice that had no ROR gamma T. So that is a gene that's important for Th17 cell generation. And here they're showing that when they spray group A strep into the nose, in the anterior brain, in that olfactory bulb of the mouse, you don't have Th17 cells, but you don't have Th17 cells here, but you do have regulatory T cells. So it's not depleting all of your T cells, it's just that you don't get Th17 cells in that area. And down here, what you're seeing is that if you don't have the Th17 cells in this ROR gamma T negative mouse, then you get less mouse IgG passing through the blood-brain barrier. So you have more blood-brain barrier permeability if you have Th17 cells. And the way to think about the blood-brain barrier is that it's really just that the cells, the cells that line the blood vessels of the brain are different. Normally in your blood vessels, you've got little walls along the edges of your blood vessels, and normally they let things through fairly frequently. And in the brain, we don't let things in there unless we really want them there. Things like sugar, we love to have sugar in our brains. We like to have certain things pass through and certain things really not pass through. So the blood vessels of the brain are different, call that the blood-brain barrier, and things get through more commonly if you have these Th17 cells. It kind of is intuitive because if you have more inflammation, you will have more blood-brain barrier permeability, but it's a pretty cool thing to show. And then they looked at microglial activation. I'm not going to walk you through the details of this picture because it's complicated, but microglia are the resident immune cells in the brain, and they're very difficult to study because basically if you do anything to them, they get wonky. So this is pretty cool. So they showed microglial activation. And then they looked at function. And what they really looked at was the ability of the mouse to detect smells. And they saw that if you had Th17 cells, these RO1 gamma T plus minus mice, then you had a deficit in olfactory ability after you had group A strep. And if you didn't have Th17 cells, then you didn't have a deficit in olfactory ability, smell, after having group A strep. So this is pretty cool. I mean, as an immunologist, I think it's pretty cool. The problem is that it's a mouse model, right? And I worked with the mouse model for 5 years, so I can tell you, like, there are pluses and minuses to a mouse model. The huge benefit is that mice are pretty easy. You can breed them, you can, do things you want to them. In the mouse model of multiple sclerosis, you can test medications that might be helpful for humans. And 2 in specific, Copaxone and natalizumab, were discovered in the mouse model. It is still a model, though. And there are other medications that have been studied in that model and seem to work in that model and don't work in humans. And the mice don't really look like they have MS. They have an ascending paralysis that affects their legs more than their arms. It's something that you initiate as opposed to a natural occurring MS in most of the models. So this is a little bit different, right? Humans don't have the same olfactory bulb that a mouse has. And the thing that you're measuring, the change in olfaction, is different from measuring something like anxiety or OCD or tics, right? Anosmia is an interesting thing, the loss of sense of smell. You've probably heard the term anosmia because of COVID, right? So COVID can affect the olfactory cells. Anosmia can be an early sign of Parkinson's or Alzheimer's. This is all very interesting. It's hard to make, and doesn't mean the leap isn't there, but it's hard to make the leap from this to PANDAS PANS. But that doesn't mean that leap isn't the right leap to make. It just means that we need more steps along the way to make us sure that we're making the right leap. It's also very specific to the streptococcal infection. And it may be that all PANDAS PANS is related to strep, maybe that it's not, and it's hard to say. But if Th17 cells are the pathogenic thing in PANDAS PANS, then it's kind of cool because we have multiple sclerosis in adults and we have medications that work on Th17. So ustekinumab is an antibody that affects IL-23, which is a cytokine. So it makes it impossible for your body to make Th17 cells. And there are other MS medications that act on Th17 cells. They prevent that skewing in the case of fingolimod, they actually keep the Th17 cells inside the lymph nodes, so it could be helpful. What about IVIG? So I mentioned earlier that one paper doesn't show us necessarily that we need to be using IVIG in kids. So let's talk about that. So IVIG, it's this really cool stuff. It was discovered in 1901, and it was the first Nobel Prize for physiology or medicine. It's a blood product. You're taking the the antibodies out of other people, the stuff that they made in response to infections, the stuff that their B cells are generating, and you're taking it from other people and you're giving it to the person who needs it. It's dependent on donors. So if no one is donating IVIG, we can end up with shortages. And they combine a whole bunch of different people's blood products, 1,000 to 1,500 donors per batch. So it's not really anti-inflammatory. It's actually can be very inflammatory. And when you get IVIG, there can be infusion reactions, there can be anaphylaxis. We generally give Benadryl and things like Tylenol and sometimes steroids when we're giving the medication. There's also risk of things like renal failure and stroke. These are rare, but they're real. And when you see it, you know, you're upset by it. Because it's a blood product, generally blood products are tested, right? So we test for the things we know about. We test for HIV, we test for things like hepatitis. There may be other things we don't know about. And this is how we counsel parents when we're giving IVIG, because it's not without risk. So that's IVIG. And then what does it do when it gets into your body? So antibodies in general, they're really fascinating. So if you are fighting off a virus, say, the antibody can bind the virus, it can cover the virus so it can't get into the cells. And if you have little particles around, like if you have a bacteria that's just like let off some stuff that's going to be super inflammatory, the antibody will come in and bind that particle and it will precipitate out into your bloodstream. It can recruit a different immune component called complement. And if the antibody binds to a bacteria, it basically signals your body that it is the bad thing, and then your body comes in and eats it. Your neutrophils or your macrophages, which are the eating cells, they'll come in and eat it because it's been opsonized, it's been primed for the eating. What do we use IVIG for generally? We use it for certain infections. Like if you get botulism, then we give people an antibody that comes from other people who've been exposed to botulism in a dish, not in person, and then you can and then you can try and prevent botulism, or tetanus or other things. You know, it was discovered with diphtheria. You give someone, it's kind of like you're giving someone else's vaccination. They've made the antibodies to it. You just give them the antibodies. We use it in primary immunodeficiencies. So if your body can't make its own antibodies, then we're going to give you somebody else's antibodies, and that can be very helpful. Kawasaki's disease, which is a cardiomyopathy that occurs after infection, that can be very helpful. We also treat that one with aspirin. And we use it a lot in inflammatory diseases of the peripheral nervous system, like Guillain-Barré syndrome or AIDP, or what's essentially like a chronic Guillain-Barré syndrome or CIDP. It can be very useful for that. And we use it in idiopathic thrombocytopenic purpura, which is an inflammatory clotting disorder. We don't use it that much in central nervous system inflammation. We don't use it in multiple sclerosis. We don't use it in neuromyelitis optica, though there's a new variant of neuromyelitis optica that we call MOG syndrome, and we're currently testing it in that. If you have inflammation in your spinal cord that's causing demyelination, transverse myelitis, or inflammation in your optic nerves, we don't use it. For these things, generally, we're using steroids. We're using high-dose steroids when it comes in because those are the things that really smash down the immune system and prevent the destruction from happening. In acute disseminated encephalomyelitis, which is an inflammatory brain illness that can occur in kids after infection, we don't use it. In SLE or lupus, if you have neurological or psychiatric manifestations, generally it's not the first choice. And then if you have an actual infection, if you have meningitis or encephalitis, it's not what we use. And we partially don't use it in meningitis or encephalitis because it causes its own kind of meningitis, this aseptic meningitis that can happen from inflammation when you give IVIG. So in general, when you have inflammation in the brain, you're less likely to use IVIG, which does not mean that it doesn't work in PANDAS. It's really just, you know, these are the facts about IVIG. We do use it in autoimmune encephalitis, but generally, this is a treatment flow chart for NMDA positive autoimmune encephalitis. We're going to use it initially. We're going to use it with a high dose of steroids very early on in the disease, with the idea that you're just trying to like smash that inflammation down as soon as you see it. And then once you actually get that first dose in, then you're going to use things that are more specific to the pathophysiology, and you're going to not be treating with IVIG long term. There are 2 placebo-controlled trials of IVIG and PANDAS PANS that we're going to talk about today. And if you want to learn more about placebo, there's this great podcast on stem cells, and it has an excellent discussion of placebo. It's called Bad Batch, and it's done by the Wondery. And I thought it was very cool listening to it. I think it's episode 4 that talks about the placebo effect and how it works. And I thought it was just a great description, and I don't have time to go through it today. I could spend the entire hour talking about placebo. It's a fascinating thing the brain does. So a placebo is a beneficial effect of a medication that you can't say came from that medication. And it happens most in things that are subjective, which makes sense, right? In pain and headache and sleep, in stomach upset, and in psychiatric conditions like depression. Children have a greater response to placebo than adults, which is kind of backwards, right? You'd think that adults would have it more, but in every placebo-controlled trial, adults know that there's a good possibility they might be getting placebo. And so kids actually end up are harder to test in placebo-controlled trials. And then there's the idea of the nocebo, which is where you take a placebo medication and you actually have negative side effects from it because you take a regular medication and you have negative side effects that are a negative placebo effect, essentially. I talked about this last time. This was an amazing study looking at cannabidiol for seizures in a specific epilepsy called Dravet syndrome. Cannabidiol is a component of marijuana, and there was a lot of excitement about using this for seizures in general and Dravet syndrome in particular. And when they tested this on kids, they used as their outcome measure a reduction in convulsive seizure frequency by 50% or more during the treatment period. And 1 in 4 patients in the placebo group, their parents reported this kind of decrease in seizure frequency. Now, of course, if they're in this study, we're using kids who have a lot of seizures because that's how you can easily tell a difference between the groups. If you have 1 seizure a year, you're not going to be able to put them in the study because you wouldn't have Dravet syndrome, but also you wouldn't be able to say that the medication is working. And I mostly include this because it was just so mind-blowing. Knew that placebo effect was there, knew that it was definitely a problem with headache studies. And yet, like, even if it's something that seems like you couldn't overlook, like seizures, you still get a placebo effect if you really believe in the medication. And medications that have fewer side effects, you can imagine you get more of a placebo effect in a study. Because if you know that a medication is going to cause a rash, and you don't get a rash, then you're more likely to know that you might be getting placebo. And so I think that the fact that cannabidiol doesn't generally cause a lot in the way of side effects may have made this pop out a little bit more. So the first study actually really wasn't to address PANDAS because at the time there was an idea that maybe all OCD and tic disorders might be from a strep or PANDAS kind of idea. So they took kids who just had OCD and tic disorders, and they said the titers of ASO were similar in both groups, and they weren't really looking for people who'd had strep, any kind of PANDAS phenotype. And they did this, a lot of studies are like this. They took 10 kids and gave them IVIG. They took 10 kids and gave them placebo IVIG, and they took 10 kids and gave them plasmapheresis. You can't really give placebo plasmapheresis because you're basically taking the blood out of a person when you do this, and then you take out all the cells and you take out the serum, and then you throw out the serum and you use a substitute serum, either a donor serum or a synthetic serum. And then they gave them one dose essentially. So they got 1 dose of IVIG or 1 dose of plasmapheresis or placebo, and they looked at them 1 month later. And 1 month later, they saw a difference in the IVIG group versus the placebo group versus the plasma exchange group. So it seemed like the medication was working. And then they took the placebo group and they divided them back into IVIG or plasma exchange and just gave them medication. The criticism of this paper at the time was mostly that they didn't look a year out in placebo, which I appreciate would have been hard for the families. And it's hard to recruit someone to a study and say you could get placebo and it could last an entire year. So oftentimes we do offer this open label component of a study so that you get placebo, but then you know you're getting the medication later on. It's just hard when, it could be that these placebo kids would have gotten better with time, and it's hard to say. And then it's also hard to know if these are really the PANDAS PANS kids we want to be looking at. So Susan Sweato was on this paper, and she then again did another study looking at IVIG, and this time looking more specifically at PANDAS PANS, or PANDAS really. So she was looking at PANDAS moderate to severe COPD symptoms that had to happen within a certain amount of time from a group A strep infection, 6 to 8 weeks. And it had to have been within the last 6 months. So new onset PANDAS essentially. And they gave either placebo or IVIG, and they didn't see a distinct difference. You could argue that there's a difference, right? But it's not a statistically significant difference. It's not enough to warrant really giving someone IVIG. And then, like I mentioned with most trials, they gave them an open label IVIG. So at this point, you're seeing this first part of the trial. You're seeing that half of them got placebo and half of them got IVIG. And then everyone got IVIG, and everyone knew they were getting IVIG. And within 6 weeks, everyone had an improvement. And then continued to have that improvement over time. So what does that mean? Maybe everyone gets better with or without IVIG. Maybe they're just going to have this decrease at 12 weeks, regardless of whether or not they got a medication at all. Maybe they had a placebo effect here. And once they knew they were getting an actual medication, that placebo effect was much stronger than when they thought they could either be getting a placebo or the IVIG. You could argue that the placebo group might have been different. And with a small study of 18, maybe that's possible. Maybe the placebo group could respond within 6 weeks, and maybe the IVIG group took 12 weeks to have this same decrease. I mean, I think it's unlikely. I presented this to one group and they said, well, how do I know those PANDAS patients are my PANDAS patients? And that's a thing when we do have a clinical diagnosis and we have no biomarkers to say 100% these are the kids we're looking at. I can't ever say those are the same patients that you are seeing in clinic, right? I can say that Williams and Sweato are the people who work with PANDAS. They know PANDAS. I trust them as being people who would pick the right people out for this trial, but I can't ever say that this is the right trial. And that's the problem with the issue with the biomarker. But it certainly looks like most of this response to IVIG was a placebo effect. And that's, again, these are the 2 papers that we have. And this is when I talked to people at the time, it seemed like everyone was pretty certain that IVIG wasn't the thing for PANDAS PANS. So there's another trial that's recruiting. I don't know where they're doing it. I actually emailed the group and asked if we could be a site. I haven't heard back from them yet. And hopefully this will be something that will put this issue to rest, because what we really want is the truth, right? We want to know, does this help or not? Does it help over placebo? One of the questions was, how many people would you need in a trial to say that you believe in IVIG? And that's not really the question. I'm not really the one to convince. Really, we want to know the right answer, right? We want to know what's going to help kids. But I can say statisticians think of this in terms of power. So if you have a large effect, if you know that it's really going to make a huge difference in your patients, that it's really going to be the difference between whether they, that it's going to make this huge dramatic difference in heart rate, say, then you can have only a few patients because you've got such a huge difference that your error bars aren't going to cross over. But if you have a subtle effect, then you need a lot of people. So if this difference is real here, because you can see that the IVIG line is lower, if you had enough people, you could maybe say that that difference is actually really real, because those error bars would become much smaller as you have more and more people in the study. So that's what statisticians think about when they're designing a study. I'm certain that the people at Octapharma are thinking about that. How big and dramatic the differences with IVIG will make a big difference in how many people you're going to need in a PANDAS study. So I'm going to change courses a little bit and talk about a totally different disease, and I promise that there is a point to this. So I'm going to talk about acute flaccid myelitis. So this is a thing that was discovered back in, it was described back in 2014, where kids, usually prepubescent, would come in with this flaccid floppy paralysis, where upper more than lower extremities, where they couldn't move their arms. So they'd be moving their hands, but then their shoulders would be all floppy. And cranial nerve palsies, and we talked a little bit about this last time. That means things like a facial droop, or not being able to move your eyes, not being able to swallow, not being able to hold up their heads. We call those bulbar symptoms sometimes because they're coming from the brain stem. And they did have biomarkers, and specific this bright white line that occurs in the central gray matter of this spinal cord. And you can see it on MRI. You get this bright signal right through the gray matter. And when you do a lumbar puncture, you also see inflammatory markers. You see a high white blood cell count, and you see a high protein. And we knew that when people got enterovirus D68, you saw more acute flaccid myelitis. So enterovirus D68 is a virus that is kind of a little bit like polio. And in some ways, this looks like polio, although polio tends to affect your legs more. So when you get enterovirus D68, most people just have a cold. And when we see a lot of people with enterovirus D68 colds, we see more acute flaccid myelitis. And this is a picture from the CDC. You had an outbreak in 2014, you had an outbreak in 2016, you had an outbreak in 2018, and then you had in 2020, nobody got sick because everyone was home and wearing a mask. And so you didn't have acute flaccid myelitis either. And so like something like PANDAS PANS, where we're like, well, we can't say for sure, but heck, this seems to happen a lot when this other disease happens. Acute flaccid myelitis, it seems to happen a lot when enterovirus D68 is going around. So we think that it's probably connected. And we don't have evidence in this that IVIG is helpful. We haven't done placebo-controlled trials, but we've looked at a lot of kids. When they come in with this floppy paralysis, and they maybe get better a little bit, or maybe they don't. And the IVIG really hasn't been seen to be helpful. Looking at big studies with epidemiologists and with statisticians. And here's the deal. We use it anyway. We use it anyway because kids are super sick and they have a paralysis. And I don't know any neurologist who feels really comfortable saying, none of the medicines we have work for your kid with paralysis, so I'm not going to do anything. We use it anyway. And I think that that's the thing. Like, I mean, I may say to you, like, I don't know for sure that IVIG works for this. I think it probably doesn't work any better than placebo, but if your kid is sick enough, it may be worth a try. And if your kid gets better, or you feel that your kid is better, does it matter to you whether or not it's placebo? Maybe not. I do think that it's important to be honest about it. I would never give IVIG to a child with acute flaccid myelitis and not talk to the parents honestly about the risks versus benefits, and that we don't know. And the CDC says on their website, we don't know that it works. We don't know that it doesn't work. We don't think that it's necessarily very harmful. So we just kind of do it because that's kind of what we got right now. I do think it's wrong to say this is the thing and that this is the only thing we're ever going to use and not look for something better, because kids are really sick and we want to make them better. And in this case, IVIG, in acute flaccid myelitis, IVIG really isn't the thing. So what else can we use in something like PANDAS PANS? So Elizabeth Latimer is a physician out in DC, and she mostly seems to use rituximab and plasmapheresis from my understanding. But anyway, she's on this paper looking at what's in an ENT journal, an otolaryngology journal. So they talked mostly about tonsillectomy and adenoidectomy and said, okay, so parents who have various treatments, if they have tonsillectomy, they tend to think that tonsillectomy is the thing that helped the most. So, but really that's kind of the headline, but hidden in this paper, in the main part of the main figure of the paper, is just looking at all kids, all comers, all treatments with OCD, with tics, with trouble sleeping, and with general anxiety. They tend to get better over the first year. They tend to get better with time. Whether you use antibiotics or IVIG or a tonsillectomy or rituximab, which is a medication that destroys your B cells so that you can no longer make antibodies. It's used a lot in chemotherapy for cancer, and we use it for things like sometimes multiple sclerosis or neuromyelitis optica. No matter whether you hit it really, really hard or whether you just use some antibiotics, people tend to get better over time. And I think that is a really interesting study. This just came out a couple of months ago in 2021. And they say across all treatment groups, there was a decreased frequency of symptoms, and what people were happiest with was tonsillectomy and adenoidectomy. a tonsillectomy is a surgery, so it's not a completely benign thing to recommend for kids. What I'll say is that we used to get a lot of tonsillectomies, and for the most part, people are okay. It helps with sleep apnea, and I wonder how much something like a problem with sleep makes this kind of thing a lot worse. So it is a thing to think about when you're thinking about treatment for PANDAS PANS. Plasmapheresis is that thing that I mentioned earlier, where you take the blood out, you process out the cells, you take the serum, you replace it, and then you give it back. And the reason I bring up this paper is not so much to say that plasmapheresis is necessarily going to be helpful, because you can't do a placebo-controlled trial for plasmapheresis. So you always have to wonder, if people get better, is it something like this, where they're just kind of responding to the fact they're getting treatment? But they looked at a lot of kids, and they looked at them many years after they presented with their symptoms. They looked at 8 to 10 years, 12, 14, after they first had their symptoms. And some people responded very strongly to plasmapheresis with 100 or 90, 195, 90, 80% improvement when they got plasmapheresis, even if they'd had symptoms for years. And the reason I mention this is because I think that as a parent, sometimes you're just like, gosh, if my kid is sick, I don't do something today, I may be destroying their whole life. And what I'm telling you is that you can apparently treat 8 years out and still see a huge benefit. You can wait and see how things go, and you could wait for that year and see if you have improvement, like was seen in that paper looking at tonsillectomy. If things aren't terrible right now, it's okay to say, let's see how things go and see if things become terrible, because maybe they won't. And maybe talk to someone about making sure we're not missing other things, but there's not a need to like really be super aggressive and give your kid really strong medications if they're doing okay. One of the questions was, what about autism in PANDAS PANS? I really appreciate this question. Again, thank you so much for asking it, because it gives me a chance to talk a little bit more about autism as a neurologist. And I probably won't do a whole Swindells presentation on this unless you guys clamor for it. But I'm not someone who diagnoses generally or treats autism, but I want you to know how I think about autism as a neurologist, because I do see a lot of kids with autism, and I am approaching it from a slightly different direction. So autism is a clinical diagnosis like PANDAS PANS, and it comes from the DSM-5 right now, right? And so it's deficits in communication and repetitive patterns of behavior, and then some other stuff, but basically those are the two big things: communication problems and repetitive patterns of behavior. And then you check those boxes and you get autism. And as I mentioned before, you probably know kids who have the diagnosis of autism, and you're like, I don't think they have autism. And someone else doesn't have the diagnosis of autism. The parent's like, they wouldn't give it to me. And you're like, what? I think they have autism. Like, it's a clinical diagnosis. Whoever looks at you can decide whether you fit in that criteria or not. They can't draw blood. They can't say, oh, definitely you qualify. It's just a clinical diagnosis. And clinical diagnoses change over time. So back in the 1980s, this was the criteria. And look how much shorter it is than this DSM-5 criteria. And some of it's that we didn't quite understand it as much. And some of it is what in that diagnosis is useful to us. How is the ASD diagnosis useful? Some of it is kind of cultural, right? Because if you can get insurance to pay for more things, so you give this diagnosis, you're going to change the diagnosis to fit that. Yes, in 1980, this is 1987 with the DSM-3 and 3R, and they already had like a whole lot more in there. But basically, it's still the same thing. It's still going to be things like communication and repetitive or restricted repertoire of activities. So much like something like seizures, I see some with seizures, and I don't know, they have a seizure, certainly. There's something different about their brain. If I see someone with autism, there's something different about their brain. But part of my job as a neurologist is to say, well, why might you have autism? Why might you have a seizure? I think of it as a symptom, like a headache, where part of my job is to think, well, why is this happening? And can I figure out the underlying diagnosis for you? Because it is this clinical diagnosis, lots of different people check off these boxes. Know that a lot of different genetic abnormalities, like chromosomal changes, deletions or duplications, Fragile X, Angelman, Prader-Willi, some specific gene variants can lead to autistic spectrum disorder. And the AAP, the American Academy of Pediatrics, recommends that all kids with autism get a chromosomal microarray. The way I think of that is if your kid's genes are a book saying how to make your child, then you're saying, are all the chapters there? Are all the chapters the right size? You're not saying whether all the words are spelled right in the book, but it's a first step to say, like, just big picture, does that book look right? And sometimes we find something and sometimes we don't. And then things like Fragile X testing is also recommended by the AAP. Sometimes it's structural brain abnormalities, meaning a physical problem. The brain looks physically different, like in something like tuberous sclerosis, which is also genetic, but you have a structural difference. Polymicrogyria, schizencephaly, Dandy Walker. If you want to know more about this, I recommend you check out our podcast for the Journal of Child Neurology, because we have a new series on structural brain abnormalities. Sometimes you have a metabolic disorder, which is generally tested for in the newborn screen, but sometimes not, and sometimes missed, or mitochondrial disorders that can also lead to autism. And if you have an injury to the brain that happens early on, like a stroke or being very premature, maybe having a hemorrhage in a ventricle or hypoxic ischemic encephalopathy with deprivation of when the brain is deprived of oxygen at birth, those things can cause autism as well. So we look for all of these causes, and if we can't find anything, we call it idiopathic, meaning that we've looked and we can't really find anything. It doesn't mean there's not a reason. It just means we don't know what it is. So I think that the question really that the asker was trying to get at is sometimes when kids have idiopathic autism, what you see is everything seems to be going along fine, and then they have a regression around 1 to 3 years of age, and they lose a lot of verbal skills and they lose a lot of social skills. And could that be the same thing as PANDAS PANS? It's a great question. It's so interesting because we know that infection and inflammation can change the brain. I think it's something different. I don't think I would call it PANDAS PANS because you lose the verbal skills and you lose that the social skills, and it doesn't tend to ever get better with time. Whereas with PANDAS PANS, you have things like the tics and the OCD and the food restriction, very different clinical symptoms. And in general, it seems like kids get better with time. So, and also the age difference, I think, matters. I think whether it happens to you when you're 2 versus when you're 8, it's probably a different pathophysiology. I don't think we gain a lot by lumping it together. I don't think it would really help us think about it in a better way. So I think for now, until we have more data on both of those phenomena, I would keep it separate. Although I appreciate that that is a very interesting, it's an interesting association. So good job on putting that together. The second part of that question was whether a kid who has autism should be evaluated for PANDAS PANS. And I'll just remind you, there's no way we can. Oh, so it's not all regression is PANDAS PANS. So yes, should that child with a regression who has autism, they should be evaluated by a neurologist because they could have a leukodystrophy, they could have a brain tumor, they could have a mitochondrial disorder, they could have something else that's going on that we might treat very differently. So if your child is having a dramatic sudden regression, you should have them seen, not necessarily with the PANDAS PANS thought in mind, but to make sure you're not missing something else. And then we can't ever rule out PANDAS PANS, so I can never say that these kids don't really have the same thing. Again, I think it looks different, but that doesn't mean it's not the same thing. But I don't think you need to necessarily rush your kid in. If you do have a child with a diagnosis of ASD, and you're concerned that they now have PANDAS PANS, I see these relatively frequently. I think that the main thing is to make sure that you're not having another issue. So if a kid is nonverbal, it's very easy to miss other stuff. And I've had 2 kids with nonverbal autism who came to me and were having these intermittent episodes where they seemed very distressed. They looked very pale, upset. They weren't eating. And they would do things like hit themselves or bite their hands or just be really irritable with everybody, these formerly very sweet kids. And it turned out that we treated them for migraine and they did great. I think that if a kid has pain from something like a tethered cord, which we can talk about at some point, if a kid is irritable because they're not sleeping well, if they have sleep apnea or some other sleep problem, then they could look like someone with PANDAS. If a kid is having seizures, I had a kid again with autism who came in. It turned out he was having this very unusual seizure type. I think making sure that something else isn't going on. If your kid can't say to you, "This is how I feel," and if they haven't been a kid who's been totally neurodevelopmentally normal who fell off, then I think you have to be really cautious about whether you call it PANDAS or not, because it's less likely that some kind of these treatments will be helpful for you. It's not saying that a kid with ASD couldn't have PANDAS. It's just, I think that you have to be a little bit more cautious when you're dealing with these kids because they are generally pretty complex. This is the last question I'm going to talk about today. So I didn't get to your question. I think I tried to hit on everything. Or if you have more questions, again, please reach out to us because we love to answer questions. How can I tell if my child has neuroinflammation? How can I reduce neuroinflammation? And again, this is just like, oh man, I love these kind of questions. So what is neuroinflammation? Neuroinflammation is when you have immune cells in the brain and spinal cord. And guess what? We all have that all the time. And that's not what you're asking. And I know that I'm not going to be silly about it. We'll get to your real question in just a minute. So in general, your brain is immunologically privileged. So you don't have a ton of cells in there. You have that blood-brain barrier, right? And in general, those cells aren't crossing through the blood-brain barrier, aren't causing havoc in the brain. But you do need some kind of immune surveillance. You need a few cells to go in and check things out and maybe smash things down if they're starting to get out of control. And we know this in part because if your immune system is off, if you're on chronic steroids, if you have HIV, AIDS, you can get toxoplasmosis in your brain. If you have, there's an MS medication that stops those Th17 cells from crossing through the blood-brain barrier. And in rare cases, people get a horrible infection called progressive multifocal leukoencephalopathy. So you need those cells to go in there. You need some neuroinflammation at all times because that's kind of how your brain keeps a bad response from happening. So there's good neuroinflammation, there's bad neuroinflammation, and that's the real question. How can I tell if my kid has the bad stuff and that's causing a problem? If you were a medical student asking me, how do I know when a child has neuroinflammation? I would say, well, you do a lumbar puncture and you take the fluid out from around the brain and spinal cord, the cerebrospinal fluid, and you look for white blood cells, which are your immune cells, and you look for protein, because if protein is high, then that's because there are inflammatory components in that fluid. And you look for oligoclonal bands or an IgG index to say that there are antibodies there as well. And if you don't have that, then you don't have pathological neuroinflammation. And if you do have that, then you do have pathological neuroinflammation. And that's how we think of it in medicine. But I can also tell you that if you get sick with anything, if you get a virus, if you get an infection, if you get pneumonia, if you get a bone bacterial infection, you're going to act the same way, regardless of what kind of infection you have. You're going to feel crummy, and we call it malaise. You're going to feel tired, and you're going to feel like you don't want to move, and you are not going to want to eat, and you're going to feel cold, and your muscles are going to hurt. And this is the same regardless of what kind of sickness you have. Every single person who gets a kind of infection looks the same. How cool is that? We call it sickness behavior. It's probably adaptive, meaning that if you didn't have sickness behavior, then you're going to have more problems because you're going to push yourself. Of course you will, even if you're sick. And so it needs to knock you out. It needs to slow you down. It needs to tell you this is not the way you want to feel, so that you don't go out and get sick again. And that sickness behavior is a brain thing, right? And it's from cytokines that are in the brain. So every time you get sick, you're getting cytokines in your brain. And probably even if you're not really sick, even if you're just exposed to stuff, if you're exposed to this virus here, this bacteria over here, maybe your body doesn't make a huge reaction, but it's probably sending up little signals to your brain sometimes anyway. And so we call that sickness behavior. And that's not a neuroinflammation I can detect in my lumbar puncture, but it's there, right? And then in something like a seizure, we know that seizures can cause neuroinflammation. And if you have inflammation in your body, if you have any kind of cold, or if you have a fever, you can get more seizures. We had like basically no seizures in April 2020. this is purely speculative. I have no papers on this. It's just kind of cool. Like, we just didn't get calls about seizures, and I assume it was because everyone was home and wasn't getting exposed to infections. And so inflammation is a big trigger for seizures. We know that flu is a terrible seizure producer. It's awful. Migraines can have an inflammatory component. We use anti-inflammatories to treat them. If you have a concussion or if you have a stroke, there are inflammatory components to that too, and you can detect changes in cytokines, and you can detect inflammatory things. It doesn't mean we always treat those things with anti-inflammatory stuff, right? And there's been a lot of look at injury and whether and strokes and whether anti-inflammation is helpful in that situation and isn't detectively. There was one question specifically about low-dose naltrexone. So this is an antagonist to the opiate receptor. And if you overdose on opiates, we give you a high dose of naltrexone and then you don't die from your opiate overdose. But if you give a low dose of naltrexone, the idea is that it causes your endogenous opiate system to increase the receptors. So it starts looking for more opiates. It looks for more endogenous opiates because you've got this low dose naltrexone. There's been a good amount of studying of this in some GI inflammatory things and also in multiple sclerosis. What I'd say is that it's never a thing where you could say it's the only medication you need for either thing, for inflammatory bowel disease or for multiple sclerosis. It does seem to help with pain. And the thought is that it might affect the neuroimmune system through the toll-like receptor number 4, which is a way that your body generally responds to bacteria. I don't know about the answer for PANDAS PANS. I think it's a pretty low risk thing to try if you're concerned. I don't have great data that it's necessarily going to work, but I think, again, like, not everything is going to work for everybody, and it really seems to be very low risk. It doesn't have a lot in the way of side effects. So again, like, if something is super anti-inflammatory, it's going to have side effects of giving you infection in your brain. This seems to be a pretty low level anti-inflammatory, and so would probably be totally fine. And I think the main question for this, how do I stop my kid from having neuroinflammation, comes down to the question of how do we keep our kids healthy? There aren't a lot of ways that I can say to, like, decrease neuroinflammation in a way that I can really back up with data. Like, I don't know if turmeric's going to be helpful. If you think turmeric might be helpful, you could certainly give it to your child. I don't think we're going to find one food that decreases neuroinflammation that makes everyone healthier. We've been on this planet for long enough that if that were there, I think we would know it by now. But we do know that certain things are healthy, and we do know that when things aren't healthy, they generally aren't healthy in a way that causes derangement of your immune system, right? So, like, sleep. Sleep is good for you. We know that in adults, when they have sleep apnea, when they have problems with sleep, if they stay up for a week, then yeah, you get more inflammatory components in your body, and that's not good for you. And also you feel bad, and also you can't remember anything, and that's all bad. So in general, with kids, we're going to focus on sleep hygiene. If you haven't seen my earlier talk on sleep or my earlier talk on migraines, I talk about sleep in both, and so you might look back on those. Sleep hygiene in 2021. Not using the television, not having a television in your room, and not using your laptop. A lot of people use apps to try to calm themselves and go to sleep. I'm on the fence about it. I don't know. I feel like, reading a book is probably better. You don't want the light. Just don't have the light from your phone. If you have to listen to something, that's okay. But the light from your phone is a strong input telling your brain that it needs to be awake right now. And that's where we start. Some kids have sleep apnea, and when kids have sleep apnea, it is often subtle, much more subtle than in adults. And it's generally because those tonsils and adenoids are getting in the way of your airway. So they swell up, and then you can't breathe at night. If you get sick, your tonsils are going to be bigger. And I wonder if this parental satisfaction with tonsillectomy and adenoidectomy has to do with strep, or whether it has to do with treating sleep apnea. I don't know the answer to that, but if your child has sleep apnea, if your child isn't sleeping, everything is going to be worse. It is, you know it. You know how it was when you had a baby. If you're not sleeping, you're just miserable. So it's a thing to be thinking about with kids with issues. Melatonin, generally we start with those first steps, making sure there's not a medical problem, and sleep hygiene. Melatonin is a medication, but it can be a good one to help with phase shifting, making sure your kid goes to bed on time, and sometimes can work as a hypnotic. So there have been very good studies of melatonin, and it doesn't seem to make a problem long term. And so if that's what you need for your kid, that's what you need for your kid. Diet. I get a lot of questions about diet, and I don't think there's going to be one diet that works for everybody. If there were, then we wouldn't have a million different books in the bookstore on different diets. And if I knew the best diet, I would go write one of those books and I would make $1 million and I wouldn't be here right now. So I don't think that there's a right answer for you. Generally, what we know, diet is very hard to study, for one thing, because people eat different things. And it's very hard to make someone stay on a diet for long enough to see a difference. You know that sugar is bad for you, right? We know that it causes inflammation. If you have sugar on its own, it causes big spikes and drops in your blood sugar. Your body doesn't like that. So a low sugar diet, a keto diet, a paleo diet, those are going to be generally better for you. And that's kind of as much as I can say about diet. There was a specific question about the Nemechek protocol, which is thought to be an anti-inflammatory diet. I can tell you with anti-inflammatory diets and multiple sclerosis, which has been studied for a long time, generally it's not going to be the only thing that controls your disease, right? You're going to need a medication as well. But when the low carb thing was popular, the big thing was a low fat diet for MS. Now it's more a Mediterranean diet. And you can see that that's kind of cultural too, right? I think a Mediterranean diet is going to be a generally healthy diet and it's not going to hurt you, and may have a difference in neuroinflammation too. Constipation is tricky because obviously we'd like to manage constipation with your diet. We'd like to have your child eat lots of fresh fruits and vegetables and never be constipated. I can tell you that when kids get constipated, and they are kids who have a lot of seizures, they tend to have more seizures. So when I talk to parents whose kids are having more seizures, I say, are they sleeping okay? Are they sick? Are they constipated? Because for some reason, constipation does seem to make that kind of thing happen more. So maybe that isn't a neuroinflammatory component. And I do think that that is a thing that makes your body very distressed and is an important thing to keep in mind when you're taking care of your child. The Nemechek protocol is supposed to be an anti-inflammatory diet, and it's it's a fish oil and also olive oil and also inulin that you're giving to your body in the idea that it affects inflammation. I don't know if it affects inflammation or not. What I can say is I've had a number of patients who've tried it, a handful, and generally it really manages their constipation. Generally they come off it because it makes you really runny, all that oil. I think I think those things are pretty harmless. I think if you're trying to cut out gluten, or if you're trying to cut out red meat, or if you're trying to cut out dairy, I think that those things are pretty harmless. But generally, you try it and see if it works for you. And I think if cutting out gluten made everyone feel better, then we'd know by now. But I think that if it works for you and your family, that's a totally legitimate, safe, healthy, natural thing to do. So sugar is the one thing I can say. I'm not a huge vitamin person. In general, vitamins don't seem to make a huge difference in humans' health, but vitamin D is one that we are generally low on. And I worked in Alabama, so I can say it's not just the Pacific Northwest. We're all low in vitamin D. And I worked with multiple sclerosis, right? And we can say that people who lived in higher latitudes before the age of 15 tend to have more multiple sclerosis. And we think that vitamin D is the issue. And vitamin D has been very well studied in multiple sclerosis and as both the treatment and as a provoking thing. So my kids take 2,000 international units a day in a gel cap form because I'm pretty vigilant about it as someone who studied MS. If you take a little bit less or a little bit more, you know, I think that's fine. I don't generally check it. It's going to be low if you're not taking a supplement, so take a supplement. I think of all things that you can do supplement wise, this is a pretty reasonable one. And I haven't really heard about vitamin D toxicity except in very extreme situations. So I think 2,000 international units is unlikely to be harmful. It's a little bit higher than most people recommend. If you want to do 400 or 1,000, that's totally okay. Exercise. Exercise is an example of positive neuroinflammation, right? Because you actually see an increase in inflammatory factors with exercise, but it helps your brain learn. It helps you feel better. And so it's an important part of health as well. Definitely has fallen apart in the last year, and I completely appreciate that. I'm with you on that too. That's an important piece. Smoke, not smoking in the home. Smoke is very inflammatory. Cigarette smoke, marijuana smoke, the smoke from the wildfires, it's all bad for you. Avoid it if you can. And then stress. And stress is a really hard one because many of the stresses in your child's life are hopefully good stresses, like doing a test or doing a project, and in the end you feel good about yourself, or being in a play or playing in sports and being on in a game. Like, all those things are stressful, right? I don't want your child to be free of stress. I want your child to have the kind of stress where you have a accomplishment you can do, and then you feel better about everything because you did that and you feel good. And but we know that when children have adverse childhood experiences, or ACEs, that it affects your health, and it affects your health not just in childhood but for the rest of your life. And if you have a child who's sick, and especially if you don't know why, and someone's telling you that you don't necessarily know exactly how to treat it, that is all extremely stressful. And I absolutely appreciate that. If you haven't ever heard of ACEs, adverse childhood experiences, I recommend that you look it up. This is from the CDC website. It's kind of astonishing how much it affects our health, not our brains, not our psychology, not how we feel about the world, but whether we have diabetes or heart disease or strokes. The idea that your brain is somehow separate from your body is a false dichotomy. They're all part of the same system. And the things that affect us strongly as children really affect our health. So we try to avoid ACEs, and we're trying to find ways to mitigate ACEs when they happen. You can find quizzes online where they ask you to say, like, what kind of adverse childhood events you might have been exposed to, and you can get a number. But you know, whether or not something is an ACE is so much about how it was approached and how it was dealt with. And I would reiterate that in all of the things about the treatment guidelines for PANDAS PANS, there's always a piece of family therapy and personal therapy, because how we deal with stress is going to be super important for everything going forward. And how that affects neuroinflammation, I think we're all pretty sure that it does, that there is a immunological component to this emotional stress. We don't know exactly how yet. And in some ways it doesn't matter. The main thing is to figure out how to deal with the stress emotionally so that we don't get long-term health effects. I hope that I answered most of your questions today. And again, if you have specific questions about a specific case that you want to go over with me, I'm always happy to see you. So I and the other neurologist in my group, Dr. Kim, we're mostly booking out until late August. We have a nurse practitioner who works with us as well, who does headaches and tics, and she is generally available within a couple of weeks. If you have something that's more urgent, ask your pediatrician to give me a call, because I swear I can get you in faster if your pediatrician calls me and says there's something going on that we need to address right now. Okay, so if you hear that there's an appointment but it's only in September, just ask your pediatrician to call me, okay? If I don't seem like I'm the pediatrician for you or the pediatric neurologist for you, then please reach out to the Northwest PANDAS PANS Network. They have other resources. They have other people you can talk to. And they have other families that you can talk to. And so you have a support group. So that's so important, again, for that stress component. We all want you to to have the support that you need to get through this. It's been a very difficult year, and especially for parents. This is me at the Providence Pediatric Multiple Sclerosis and Neuroimmunology Center. Thank you guys so much for coming and sticking with me through this whole long discussion. And we have our podcast series that talks about neuroinflammation. And if you go to this site that talks about the podcast, you can also find the ones on things like schizencephaly and polymicrogyria and those big words that I used earlier talking about structural brain malformations, because that will be there too, with Sonika Agarwal from the Children's Hospital of Philadelphia. Thank you so much. I'm so happy to do this again. And if you want to do this a third time, we can do it. Just let the folks at Swindells know. And if there's something else about neurology that you really, really want to talk about, I am here for you. So let them know. Okay. Have a great night. Thank you so much.
Thank you to Dr. Christie for sharing your knowledge, and thank you all of us for joining us this evening. Let's see, I have something I want to share. Sorry, that took just a minute. Again, thank you so much, Dr. Christie, for sharing your knowledge, and thank you all for joining us. If you have additional questions related to this topic, general questions, or resource needs, please contact the Swindells Resource Center at swindells@providence.org or at 503-215-2429. You will be receiving a post-event evaluation via email after this presentation. We invite you to take a few minutes to complete the evaluation and give feedback on how we can improve your experience, as well as note other topics you would like to see in our caregiver education program. When you complete the survey, click Submit to ensure your feedback is captured. For those of you needing a certificate of attendance, please complete the evaluation and a certificate of attendance will be emailed to you. Again, we want to thank Dr. Christie and our Providence Children's Health Foundation for their generous support. If you have additional questions or resource needs, please contact us at 503-215-2429 or at swindells@providence.org. Have a wonderful evening.